Hi, everyone. I am Dr. Julianne Pollard-Larkin, and I'll be your host for this episode of RT Answers, where we will be talking with essential members of your care team who you may not be familiar with, the medical physicists. As a medical physicist myself at MD Anderson Cancer Center, it is my pleasure to be your host as we explain our roles and answer some of your most common questions as patients. Virtually, we have an illustrious group of experts to discuss this topic, including medical physicist colleagues in radiation therapy, including Doctors Todd Atwood and Dan Skanderbeg, both hailing from the University of California, San Diego, two medical physicists who work in a radiology department, including Dr. Cynthia McCullough from Mayo Clinic and Rebecca Millman from the University of Colorado. In addition, we are joined by two physician colleagues. Dr. Catherine Yashar from the University of California, San Diego, who is a radiation oncologist and president-elect of ASTRO, and Dr. Donald Fresh from Duke University, who is a radiologist. This episode of RT Answers is being sponsored by both the American Society for Radiation Oncology, ASTRO, and the American Association of Physicists in Medicine, AAPM, which is an organization of over 10,000 medical physicists from the US and beyond. And yes, there are truly that many of us medical physicists in the nation. So let's get started. This conversation will first address imaging and radiology concerns, and then finish with common radiation therapy questions. To kick things off, let's hear from Dr. Cynthia McCullough, a past president of the AAPM and expert in all things CT physics and radiation dosimetry. Cynthia, thank you so much for joining us today during our chat. Can you tell us about medical physicists and how they advance patient care in the radiation oncology and radiology departments? Who are these unsung heroes?
Thanks, Julie. Well, medical physics is a branch of physics that uses physics concepts and methods to diagnose and treat disease. It's really an interdisciplinary field that works to ensure the accuracy and the safety of medical diagnostic and therapeutic procedures. Medical physicists understand the biological effects of exposures to different types of radiation, and then they work to optimize the imaging and the therapeutic procedures to maximize benefit and minimize risk. They are also a great source of information about how medical imaging and radiation therapy work and the associated benefits and risks. Medical physicists are involved in a wide range of activities, including clinical service and consultation, research, development, education, radiation and magnetic resonance safety, and administration. Medical physicists are also involved in non-clinical careers, working in industry, government, regulatory agencies, and accreditation organizations. They wear a lot of hats and need to be experts in data analysis, statistics, quality assurance, quality improvement, mathematics, computer science, biomedical engineering, just to name a few fields.
My goodness, that's terrific, Cynthia. Hearing that list of responsibilities, it makes me proud to be a medical physicist. Thank you for explaining just how broad our role is. Now, most people are a little afraid of radiation, and almost everything we offer in radiation and radiology and radiation therapy involves exposing patients to radiation. I'd like to ask our Dr. Donald Fresh, a pediatric radiologist from Duke University, a simple question, or maybe not so simple, Don. Are the radiation doses used in the radiology department the same as those used in the radiation oncology department? And can medical imaging doses of radiation actually cause cancer themselves?
Thanks, Julie. These are both very important questions. Radiation is used for medical imaging, like for a CT scan or chest X-ray, but much, much higher doses are needed in radiation oncology, where the level of radiation is supposed to kill the cancer cells. In contrast, radiation doses used in medical imaging are much, much lower, sometimes several thousand times, because radiation is used to make pictures, not to kill cells. For example, a chest X-ray is about the same radiation dose as 2.5 days of radiation we all get every day from space, the ground we stand on, and even the food we eat. We know that radiation doses used in radiation oncology to kill the cancer cells can cause other effects, such as skin redness, hair loss, and a second cancer, that is one developing years later. But these effects are not seen with the very low amounts used in medical imaging. Now, there are reports of associations of cancer in people who have had one or more CT scans, but it is important to realize that it has never been proven that CT scans cause cancer. And even if there is a risk, it would be very, very small. on the order of, say, one cancer associated with as many as 10,000 CT scans. And the benefit of a needed and correctly performed scan is far greater than any very small risk. Over many years, medical imaging professionals, especially medical physicists and radiologists, have worked very hard to reduce radiation doses through both technological advances and education.
Thank you so much, Don, for sharing such a reassuring message. Now, Don just shared how radiology doses are much lower than radiation oncology doses. But Cynthia, some patients are worried that even imaging doses might lead to cancer. Is there a need to worry about medical imaging procedures? And can a CT scan or MRI or other imaging procedure make the patient themselves radioactive?
In X-ray imaging, CT scanning, and nuclear medicine imaging exams like PET scans, we do use ionizing radiation. This type of radiation can damage DNA, which may lead to genetic changes and potentially the development of certain cancers. But this type of radiation also occurs naturally in the environment from sunlight, soil, cosmic rays from space, and radon gas in our buildings. So our bodies have developed ways to repair most all of this DNA damage. Now, medical physicists talk about the amount of radiation using a number of different quantities, but one common one is the effective dose, which is measured in millisieverts. The average annual background radiation level in the US is about 3 millisieverts, though the number can range from 1 to 20 millisieverts depending on where one lives and the type of building they live in. There is a very small chance that low doses of radiation used in medical imaging, which range from a fraction of a millisievert to 20 millisievert, could cause an increased risk of cancer. But below 100 millisievert, increased risk has not been confirmed. I always reassure patients that for a medically appropriate imaging examination, the very small potential risk is outweighed by the medical benefits. Now, as to becoming radioactive, X-rays and CT or MRI scans do not make the patient radioactive. But some types of imaging do involve injecting a radioactive material into the patient, and then until the body gets rid of the material or the radioactivity fades away, the patient will be radioactive. For most exams, that time is less than 24 hours.
Thanks so much, Cynthia, for clearing that up and breaking it down. I hope that information can calm a lot of fears. But it is not just radiation that is given to our patients. In radiology, patients often receive a special type of dye that helps doctors to see the tumors and other important anatomy. They call it contrast media. Dr. Rebecca Millman, you work in a radiology department. After a patient receives this contrast media or dye, what are the side effects? And can, for example, a nursing mother continue to breastfeed?
So the short answer to that is yes. As you mentioned, we use contrast media during some imaging exams. This makes certain parts of the body show up really clearly on the images. We use different types of contrast depending on the type of machine we're using, but only a really, really small amount of the contrast media is absorbed by the fetus, less than 0.01%, so a really small amount. And patients can continue breastfeeding as usual after their exam. If patients have questions or concerns, I always encourage them to speak with the person ordering the imaging exam or to the radiologic technologist who's taking the images.
Nice points. But speaking about breastfeeding, do these patients need to stop if they were to get a mammogram?
No. So with a mammogram, x-rays are only produced while the image is being taken. That's a part of the exam where you can hear the machine making a kind of humming noise for a second or two. And then the x-ray shut off. There's no radiation left in your body after the image is taken, so you can continue to breastfeed after your mammogram.
Nice. So, Don, are there going to be any common side effects patients can look out for after getting contrast? And then what do clinics routinely do to prevent such side effects?
That's a great question and an important one to answer. Contrast through an IV is most common, but it can also be given orally mixed with another better tasting drink to help us see the stomach and intestines. This generally just passes through the GI system without any issues. IV contrast material injection can cause, usually at the beginning of the scan, a cool sensation at the IV site, a metallic taste, a warm feeling in the pelvic area, or occasionally nausea. The CT team usually tells you about these while preparing you for the scan. Hydration is encouraged, and careful assessment of your health, including allergy history, is important because in a minority of cases, dye can cause an allergic reaction, such as hives, sneezing, and rarely some respiratory difficulties. Steroids may be prescribed for a few days prior to the examination based on certain allergy histories. The dye can also affect kidney function, but generally when the kidney is already not working well. All sensations and allergic reactions occur only at the time of the scan.
Wow, that makes a lot of sense. Thanks so much, Dawn. Now, MRI is the doseless imaging procedure, right? So should we request MRIs instead of CTs? Let's hand that question back over to Dr. Cynthia McCullough. Cynthia, you are the queen of CT scans. What are the pros and cons of them, CT versus MRI?
Well, Julie, some types of medical imaging do a better job at a specific task compared to other types. But just because MRI and ultrasound don't use ionizing radiation doesn't mean they're the best imaging tests, not if they don't show the needed information. For a brain tumor, an MRI shows much more information than a CT, but in the lungs, say, CT is more effective. When MRI and CT are equally good for what the doctor is looking for, MR may be a better choice. However, MRI is more expensive and has longer exam times, and for children, this means that anesthesia may be required, and that does come with some risk of its own. Further, MRI scanners are not as available as CT scanners, especially in rural areas, and they're not always operated around the clock, whereas every emergency department has a CT scanner running 24/7. Because MRI is so much slower, it's not a good choice when time is of the essence, such as after a bad car accident or for a suspected stroke. Now, there are also some risks with MRI, such as risk of burns, and patients with implanted metal or electrical devices may not be able to have an MRI because it could injure the patient or the device. And finally, the MRI suite can be a dangerous place if all the safety rules are not followed. The MRI machine is a huge magnet and can pull in metal objects from across the room, causing serious injury or even death. So MRI scanners are not without risk. But the key is that your doctor should order the type of imaging that is the most accurate for the body region being examined and the suspected disease they're looking for.
Well, I'm just glad that we have both CT and MRI in our imaging toolbox, as well as other techniques like PET scanning, traditional X-ray imaging, as well as ultrasound. Some patients, however, may need a lot of imaging, either as part of their cancer diagnosis and treatment or for other serious symptoms or illnesses. Rebecca, if someone has, for example, 10 CT scans in 1 year, do they need to worry about a cumulative effect of even low doses of radiation?
So that's a great question. And the answer can be a little bit complicated. So bear with me while I use an analogy here. When you get a CT scan, you're exposed to a very small amount of radiation. This radiation carries a very small chance of damaging a cell in a way that could eventually lead to cancer. The big question is, does that risk change if you have more CT scans? The answer is both yes and no. So imagine that you have a bag filled with 9,999 green balls and one yellow ball. The green balls represent the overwhelming chance that nothing harmful is going to happen after you have a CT scan. The yellow ball represents the small chance that a CT scan could cause a problem. Getting one CT scan is like closing your eyes and pulling a ball out of the bag. If you get another CT scan, you put the ball back, shake the bag, and draw again. Each time the odds stay the same, 99.99% that you'll draw a green ball and a 0.01% chance that you'll draw a yellow ball. Medical imaging should always be done when the benefit, diagnosing an illness, checking for problems, or monitoring treatment, outweighs the small risk. But when deciding whether to do another CT scan, doctors have to focus on the risk of that one scan, not the total from all previous scans.
Rebecca, that was a very great analogy. I will never forget the green balls versus the yellow one ball. I want to just take a moment to pause and give thanks to all of our radiology and imaging experts, both our physician as well as our medical physicists. Next, we're going to segue to the radiation therapy questions. Now we will hear from Doctors Catherine Yashar, Todd Atwood, and Dan Skanderbeg. Thank you all for joining us. Let's kick things off first, though, with Dan. Dan, when would a patient expect to run into one of us medical physicists while undergoing radiation therapy treatment? What kind of procedures would involve one of us physicists having direct interaction with patients? And are patients going to generally expect to be able to have question and answer sessions with their physicists?
Thanks, Julie. It's a pleasure to be here today. So there are three parts to this question. So for the first question, as to when would a patient expect to see a medical physicist? Traditionally, patients probably shouldn't expect to routinely see a medical physicist during their treatments or appointments. A medical physicist is kind of like a snow leopard or a platypus, rarely seen in the wild. I jokingly say that, but most of the time, medical physicists work behind the scenes, ensuring that the radiation therapy equipment is properly calibrated, the treatment plans are accurate, and that all systems functioning safely and effectively. Much of their work is done without direct patient interaction. However, in the past few years, there have been some initiatives involving more direct patient involvement. One such initiative is AAPM's Medical Physics 3.0, that emphasizes a stronger focus on the patient rather than just the technology, encouraging medical physicists to be more engaged, accessible, and responsive to patient concerns as part of a patient-centered care team. The second question was, what kind of procedures involve medical physicists in direct contact with patients? Medical physicists may have direct contact with patients during a consult with a radiation oncologist to discuss logistics of the treatment and appropriate treatment options. It might be during procedures such as brachytherapy or stereotactic radiosurgery, which require precise technical oversight, such as imaging the patient in their treatment position or assisting with accurate patient positioning on the treatment couch. However, even these cases, their role is usually supportive and technical rather than primary clinical care. Finally, the third part was, are the medical physicists involved in patient care available generally to answer specific questions? So yes, although possibly hard to observe in the wild, medical physicists are very friendly and approachable and are generally available and very happy to answer questions, especially those related to the technical aspects of radiation treatment, radiation safety, and accuracy of treatment. I would suggest asking the radiation oncologist, nurses, or radiation therapist if you could speak with one of the physicists. I will also put a plug in about the public education website through AAPM. The URL is medicalradiationinfo.org, and it has a wealth of information about medical physics and technology. And we even have an Ask the Experts section with medical physicists that are standing by, ready to take your questions and get back to you.
So, while contrast media is cleared quickly and for the most part harmless, cancer patients receive other medications that could have serious side effects on the body. I'm referring to chemotherapy. Dr. Catherine Yashar, what are the differences between chemotherapy and radiation therapy? Is one therapy more focused than the other? And how does that affect the overall side effects?
So for the most part, radiation therapy is directed, and so effects, both therapeutic and other effects, are confined to the area or areas where the beam is pointed or the radiation sources are placed. Chemotherapy, on the other hand, or immunotherapy sometimes, travels all over the body and is either given as a medication by mouth or sometimes as an intravenous infusion. These historical definitions are changing and getting a bit blurred, however, with the introduction of radiopharmaceuticals. Radiopharmaceuticals go all over the body, but these medications have radiation tagged or attached to them. These radiopharmaceuticals seek out areas of cancer anywhere in the body, attach to the cancer cells, and the cell is killed with the attached radiation.
Catherine, expanding on that topic of side effects, what kinds of side effects are there from radiation therapy? And are there things that patients can do to help minimize them?
Because of what we discussed before, the side effects mirror how the chemotherapy or radiation therapy is distributed. What I mean by that is radiation side effects are generally limited to the area or areas where radiation is directed, whereas with chemotherapy, there can be whole body effects since it goes all over the body. For example, radiation to the mouth or swallowing area can cause difficulty eating or dry mouth, and treating the side effects in that situation would differ from treatment, say, to the pelvis, where the patient might experience diarrhea or rectal irritation. That being said, because the body expends energy to repair changes from radiation, one might feel fatigue during radiation or after radiation. Discussing the possible side effects and how to treat them is best done when the patient meets with the radiation oncologist, so the radiation oncologist can review where the radiation is going to go, what the possible side effects are, and how those would be treated.
Now, I know from my own practice that patients have many questions about the technologies used in their care. Technologies like linear accelerators or CT scanners, as well as MRIs. And the most basic question happens to be, what exactly is a LINAC or linear accelerator? And how does a medical physicist ensure that these high-tech machines are operating correctly to deliver the right amount of radiation to a patient's disease? Well, as a physicist, I get to give this one answer. A LINAC is a sophisticated medical machine used to treat cancer by delivering very high energy X-rays directly to the target or tumor itself. Think of it like an extremely precise flashlight, laser focus, using radiation instead of visible light. The machine rotates around the patient and sends radiation from many angles so that the dose adds up at the cancer while reducing exposure to all the nearby healthy tissue. They even have special metal leaves that help to shape the beam preferentially to reduce dose to nearby normal structures while delivering high dose to the tumor targets. Medical physicists like myself, we're responsible for making sure that that LINAC works exactly as intended. We carefully test and measure the machine before patients are treated on them, and then continue checking it every single day using specialized instruments that measure radiation. Our job is to confirm that the radiation is aimed correctly and that the dose is exactly right. Not too much and not too little. So treatments are both effective and safe. So now let's talk into one of my favorite physicists of all time, and he already knows who he is, Dr. Todd Atwood. I wanted him to address these following questions. What exactly is a treatment plan, and how do you use it to personalize each patient's treatment?
Julie, I love this question because it's something that routinely comes up when I'm meeting with patients in radiation oncology. As a medical physicist, our role is really to oversee the design and delivery of safe and effective therapy. And a big part of this is personalizing treatment plans for each individual patient. So more broadly speaking, a treatment plan is really just like a blueprint for a patient's radiation therapy. And to make this blueprint, we need specific information from the patient. In radiation oncology, this all starts with a CT scan. These images show us the patient's anatomy in their actual treatment position. This allows the radiation oncologist to outline the precise location of the cancer we want to treat. And it also allows us to identify all the normal organs nearby that we want to protect. So once we have this information, we use sophisticated computer programs to shape and aim the radiation beams so they deliver the prescribed dose to the target area while minimizing exposure to healthy tissues. But personalization is really the key part here. No two patients have the same anatomy, same tumor location, or medical needs. So we customize the beam angles, the shape of the radiation, the dose, and even how the patient is positioned, all to fit that individual. That way, when a patient arrives for radiation therapy, they receive a treatment plan tailored to their unique needs.
Oh, I like that analogy of a plan being tailored to the patient's needs, almost like haute couture fashion. I love that, Todd. I love it so much. I want you to explain something else for me. Can you clarify something about treatment planning for us? Why can't the CT scan that I just took with Cynthia and Dawn and Rebecca from radiology, why can't I just use that again for treatment planning?
This is also a really great question, and it's often a source of confusion. So when you get a CT scan in radiology, it's typically designed to help diagnose disease. So even though the scan provides valuable high-quality images, the patient is positioned in a more standardized or generic way. For radiation therapy, we need something very different. We need a scan that represents exactly how the patient's body will be positioned every day for treatment, and something that allows us to calculate how radiation will travel through the patient's body. So in radiation oncology, we use customized immobilization, things like masks or body molds or arm supports, and even a flat tabletop that replicates the treatment machine. In some cases, we even control for things like breathing or bladder filling. This is all done to ensure that we have a scan that is beneficial for treatment planning in a position that is easily reproducible for the patient. So even though both CT scans are valuable, they serve different purposes. CT scans in radiology help us locate the cancer, while CT scans in radiation oncology allow us to safely and precisely treat it.
Thanks for explaining the difference, Todd. Sometimes, though, patients get offered different types of therapies in traditional external beam, such as proton therapy, brachytherapy, as well as other exotic options. Now, as a physicist, there are some physical properties I know about protons, these little positively charged particles that have both charge and mass that have a range that stops nicely compared to photons that sometimes leave a trail of dose behind their intended target. So for certain anatomical or disease site scenarios where normal tissue like the heart is too close to the tumor you want to treat, or for treating a pediatric brain cancer patient, protons might well be worth the expense. But how is this decided? Are protons better or just more expensive? For these questions, I will end with our Dr. Yashar.
Brachytherapy and proton therapy are two modalities that can be uniquely useful in certain circumstances. With brachytherapy, radioactive elements are placed inside or right beside the tumor or tissue thought to have cancer cells. To do this requires a procedure and specialized expertise, but the advantage is a much higher dose to the area of interest or tumor and a much lower dose to the nearby normal tissues. It allows the maximal sparing of normal tissues. Protons, on the other hand, can be useful when a sensitive organ lies adjacent to the tumor, like with brachytherapy, but you would use protons when there really isn't access to the area to perform brachytherapy. Protons, while not as focal as brachytherapy, can be really useful to treat a tumor, say, sitting right next to the spinal cord, a very sensitive area, and it avoids too much radiation to the spinal cord while treating the tumor. Proton therapy can be expensive, but it has a very unique usefulness.
Thank you, Dr. Yashar, for answering that very difficult question about protons versus brachytherapy and other exotic options. I'd like to be the first to thank all of our speakers today on this wonderful session of RT Answers. And if we didn't answer all of your questions, please feel free to reach out to us at medicalradiationinfo.org and all of the website links that are posted on the last slide of this presentation so that we can address your questions at our next physics-led podcast. Finally, I would like to thank both organizations, ASTRO and AAPM, for co-hosting this, as well as all the staff support helping put it together behind the scenes. I look forward to future joint podcasts and wish all of you well. Take care.